This work is sort of in its infancy, but it does help to describe why we might be seeing better results than we normally would see. So, what have these results shown so far? Well, if you look at the SBRT trials for patients that were not considered candidates for surgery, and here's 6 different trials that are reported, if you look under the column that says local control or LC, what you see there is numbers that are staggering. Local control numbers of 94%, 94%, 93.5%, 79%, 95%. And these are for tumors that are, generally speaking, 5 to 7 centimeters or less in size. And these overall survival numbers are quite good. And these patients have been followed for 2 or 3 years now with these sorts of numbers. What's very impressive about these local control numbers is that they exceed the numbers that you would see in the surgical series. And they far exceed what we used to see with old-fashioned, conventionally fractionated radiotherapy. When you look at SBRT doses in these different trials, what you end up seeing if you look at this table is under BED gray, that when you deliver just 3 or 4 fractions of radiation, but you deliver a big dose each time you deliver those 3 or 4 treatments, that your BED can be over 100. So significantly higher than we deliver classically with conventionally fractionated radiotherapy over 6 to 7 weeks. And it seems that that magic number is 100. When you get over 100, you tend to be more likely to sterilize these particular tumors. The RTOG did a very interesting study. This took 59 patients that were medically inoperable. They had peripherally located node-negative non-small cell lung cancer. They got 3 fractions of 20 gray, so high-dose radiation. They were followed for more than 2 years, and the local control rate at 2 years was nearly 94%. There were no regional failures and only a 15% distant metastases rate. So this is really powerful because this is the very first multi-center trial done in the United States suggesting that many centers can offer this sort of treatment to their patients, and the results can be this good. If you look in Japan, where the Japanese were some of the pioneers of this particular approach, so a large number of patients treated in a variety of different schedules, followed for more than 3 years, you can see local control rates of 86%. The converse of that is about 14% risk of local recurrence. In the group of patients that had a BED greater than 100 gray, 92% local control rate and improved survival. And this is with longer-term follow-up than we normally see. The toxicity from this particular treatment, because everything needs to be balanced between outcome and toxicity, has been relatively mild. Probably about a third of these patients experience some sort of rib fracture. Many of these rib fractures are detected on an X-ray or a CT scan, but are not clinically symptomatic. There is a small risk of developing a lung injury or a lung pneumonia called radiation pneumonitis. There's a small risk of developing what we call radiation fibrosis, either in the musculature or the lung itself. And this is something that happens, usually speaking, 6 months to a year out from treatment. Sometimes it takes longer to manifest that. There has been serious toxicity, including damage to the airways or pulmonary injury, but luckily that injury doesn't occur that often. And we're seemingly trying to figure out who's at greater risk for that and trying to do something to prevent that. This is a slide that I think is more germane to today than it was to 10 years ago, and that is that there's been an ever-changing effort, if you will, to understand what do each of these treatments cost and are they actually cost-effective. And I would tell you that understanding the costs of SBRT depend on understanding the true costs, the durability of control, the need for additional procedures. And a lot of this is complicated by some limited and immature data. So if you look just at the medically inoperable patients, the incremental cost-effectiveness for SBRT over conventional fractionated radiation was about $6,000 for a quality-adjusted life year. The incremental cost-effectiveness ratio of SBRT over RFA was $14,000 per quality-adjusted life year. So in both cases, it seems that SBRT is cost-effective relative to standard radiation and cost-effective relative to RFA or non-surgical procedures. So there are several open questions when you think about SBRT today. One of the questions is, what dose of radiation should we be giving? How many times should we be giving it? In this country, the SBRT literature was populated with doses of either 18 or 20 gray times 3. Many people use 12 gray times 4, and there are other schemes that are actually being kicked around. Another open question is, should we alter the dose and the number of doses we give based on how close the tumor is to the airway. When SBRT got its start, it was primarily in patients that had peripherally located lung cancers, and we'll talk about peripheral versus centrally located lung cancers in a minute. And then the other issue is, what are the doses that the normal tissues can actually realistically tolerate? Remember, they're not getting the same dose as the center of the tumor, but they are getting some dose at these high fractionation levels, and we need to better understand that.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.